So we are going to talk about a study where we're comparing between use of scissors and the resectoscope in metroplasty for uterine septa. That is it. Okay, I don't have any financials to disclose, I don't think. And the conclusion that we want to reach here is not just to compare between the scissors and the resectoscope, but to know when it is better to use scissors and when it is more prudent to go for the resectoscope in treatment of the uterine septa. What we did was we looked at the congenital uterine anomalies in the largest study published, which said that about 5.5% of the general population have some form of uterine anomaly, the most common of which was the U2 classification of uterine septa. And we are going to talk about 112 cases performed between January and July of 2016 at the Endoplanet Center in Cairo, Egypt, where I'm from. 41 of these cases were done by the resectoscope, 71 by scissors. And we are going to be looking at the endometrial regeneration, 1 month, 2 months, and 3 months postoperatively, residual fundal notch, which is more than 50% thickness of the fundal myometrium, and of course the postoperative pregnancy outcome, because we are not just looking to fix the cavity, we want eventually to increase the live birth rate. So when it comes to choosing the uterine, the tool we're going to use, we found that the thicker the endometrium at the time of the procedure favors the resectoscope to avoid endometrial shreds. The hemostatic effect is a lot better, of course, with the resectoscope than with the cold energy. The narrower the cornea are, we prefer to go with the smaller diameter office sheath and use the hysterectomic scissors to access the septum. And we found that the speed is more when it comes to the resectoscope. You go from side to side very fast as compared to the scissors. In terms of fluid overload, it is more dangerous with the resectoscope. It is safer with scissors. And this is mainly because we are using a monopolar resectoscope with lysine distension media, which also means that the dangers of perforation are higher with the resectoscope because the electrocautery. The skill level involved at our center, we see that the skill level is higher with scissors. It is less traumatic. And finally, the narrower the septum at its base, we prefer scissors. The wider the septum, we prefer the resectoscope. This is an example of endometrial regeneration where we found that the center, there are endometrial islands cropping up, and at the same time we have a lateral to medial creeping of the endometrium to cover the septal bed. This is taken by office hysteroscopy, 1 month, 2 months, and 3 months post-operatively. This is a residual fundal notch, where we found that the size of the notch is more than 50% of the remaining fundal myometrium, and thus it required correction during the office procedure that we performed. And finally, we have to think about the postoperative pregnancy outcome, and an ongoing trial is being performed to compare the obstetric outcome if there is a difference between scissors and resectoscope long term.